Thank you very much to the chairpersons and also to the organizing committee for including me in spite of my being late all the time, every year. But I always make an important impression to come here. So I'm going to focus a little bit about heart failure in diabetics in Ramadan and some of the aspects on general cardiovascular disease that have already been covered. So this is all very familiar to everybody about the pathophysiology of fasting with diabetes. And particularly from a cardiovascular standpoint, I think the importance of avoiding hypoglycemia is critical. And at the same time, when you have patients who are prone to volume shifts, they are very sensitive to this, particularly if they are heart failure patients, because that is the consequence of giving them diuretics and ACEs and ARBs. So just to remind us, there is a reason why we need to fast, because it's a better opportunity from a religious standpoint, but also we have weight loss, better dietary habits, and people stop smoking. They just have to. So I think this is a way to promote better cardiovascular health in general. So fasting is not for all patients, and of course, we are encouraged if there is an exception to take it, right? So God likes His permission to be fulfilled as His will to be executed. So this is an important point to remember. We're trying to facilitate, but we also have to define the risk more carefully. So I'm going to jump into heart failure because I don't know who in the audience is a cardiologist, but I just want to highlight this new definition. The definition of heart failure is the following. Some patients are at risk of developing heart failure, and those are patients with diabetes, with hypertension, with obesity. These are likely to develop or unmask heart failure. There is also the stage of pre-heart failure or stage B heart failure. Those patients have structural heart disease, i.e. a thick ventricle or LVH, and increased natriuretic peptide is the earliest stage of this syndrome. These patients need just something to tip them over and they end up with actual overt heart failure, which is the symptomatic stage C and D that we deal with in the hospital. So let's just look at this patient. This is a 60-year-old male with type 2 diabetes and history of atherosclerosis. Could he have heart failure? The answer is yes, based on probabilities only. So he is family history of dyslipidemia and diabetes. He's type 2 diabetes and dyslipidemia for now more than 11 years. Hypertension since 2015. He had a PCI done 4 months ago. He's already on an SGLT2 inhibitor with metformin, high-intensity statin, an ACE inhibitor with amlodipine and aspirin. So he has polyuria and nocturia. His BMI is 30. And the labs you see, HbA1c is 7, LDL is 56, and there is an increased albumin-creatinine ratio. So based on these principles alone, could this patient have heart failure? The answer is yes. If you have albuminuria, it increases your risk of heart failure by 2 to 3-fold. And if you have cardiovascular disease with percutaneous intervention, the likelihood of diabetic or metabolic cardiomyopathy is also very high. So remember, the clinical suspicion does not have to be overt pulmonary edema. So how do you detect if this patient in your diabetes clinic or your internal medicine clinic has or doesn't have heart failure? This screening with natriuretic peptides for early detection of relevant cardiovascular disease without an echo. And this is a very important point because in these patients, all you have to do then is consider that they may have a normal ejection fraction with heart failure. So that's another important point. It is not relevant about the ejection fraction. It's relevant if they have clinical heart failure or subclinical heart failure. And this was the subject of a very important consensus from the American Diabetes Association talking about heart failure as an underappreciated complication of diabetes. It's really very common. So this is what we're talking about, stage B heart failure. The patient here has a stiff, thick ventricle. It's not dilated, but these early stages can still unmask symptoms if they end up with stress, atrial fibrillation, infection, tachycardia, or if they stop their medications. Oops, what is that? Okay, then. I don't know. This is some virus. In any case, the point is about diabetic cardiomyopathy, and the recommendation is literally to do annual screening with NT-proBNP for every patient with diabetes, or actually pre-diabetes, which is something that we worked on in the UAE guidelines. Another question is this important? How do you diagnose symptoms in people who are generally obese and sedentary, like 90% of our population? Ask this question. Inability to exercise or avoidance of stairs and effort in general, excessive fatigue, ankle swelling, and any symptom that increases with exertion is most likely some evidence of heart failure. So just think about this. If you don't want to go up the stairs, there's got to be a reason, because I get tired going up the stairs. And it's not just due to obesity or deconditioning. Think of heart failure as this point. And again, the universal application of natriuretic peptide, whether the ejection fraction is normal or reduced, it's very easy to do in the outpatient clinic. So again, this is a plug to the UAE Cardiometabolic Guidelines 2023. And just to highlight this point, in outpatient settings, NT-proBNP coupled with an ECG and albumin-creatinine ratio help you to detect risk in these patients. So subclinical heart failure is actually present in more than 55% of diabetic patients. So type 2 diabetic patients are twice more likely than non-diabetic patients to develop heart failure. NT-proBNP in primary prevention, this is the value. It predicted first onset of heart failure and augmented coronary artery disease prediction, and it's a very powerful biomarker, and that's why we included it in the UAE guidelines. In fact, when you look at patients with diabetes and cardiovascular disease or risk factors, it's very prognostic. If it's less than 125, you don't have heart failure. If it's above 125, you have a likelihood of heart failure. So it's almost like a binary test. It is actually more powerful than HbA1c in predicting cardiovascular outcomes, and superior to albuminuria and additive when you use it in detecting outpatients. So if you're doing albumin-creatinine ratio, which I know all the diabetologists do, please get an NT-proBNP. It's just a simple way of finding your patient. And this is the discrimination index. Less than 125, you don't have it. More than 125, you have it. It's a very powerful predictive tool as well. And this is the 125 discriminatory ability. Okay. Now, the other point is it predicts new onset of heart failure. So this is a graph showing that 6 months preceding a heart failure event, it suddenly increased. So these are patients who are relatively stable. The BNP is below 125, and it suddenly jumps up. Within the next 6 months, these patients are going to be admitted with a heart failure event. Serial monitoring is also useful to see response to treatment. So this was covered by the previous talk. Ramadan fasting does not generally increase the burden of acute cardiac illness, and in fact, coronary artery disease seems to decline. There's a negative impact on acute coronary syndrome as well as heart failure. This is the post-PCI registry, and I think it showed very clearly Ramadan fasting versus the first 3 months may not be safe if you have unstable angina or non-STEMI. After the first 3-month window, you're fine to do it. So really it's a matter of timing of the acute coronary syndrome. Now, what about heart failure? So this is an important paper that actually came from the region, and it looked at patients with heart failure and preserved ejection fraction, which by far is the most common type of heart failure in diabetic patients. We rarely have reduced ejection fraction. And what did they see here? Cardiac parameters actually, improved with fasting. So the creatinine, potassium, BNP, and troponin actually went down with fasting. So there's definitely a benefit to fasting, and I would suggest that this is similar to intermittent fasting in the long term. This is Ramadan fasting compressed within a month, but it's certainly safe. So they had 938 patients. It was actually published from South Asia, and the first and largest evaluation prospectively of fasting and heart failure and preserved ejection fraction. And the recommendation is advise cardiologists to allow physicians with HFpEF to fast, as it has a favorable impact as long as they stay on medication. Now, this is another very important registry. This is the Gulf Care Registry. This is the largest registry of heart failure in the Gulf countries, including all the 7 Gulf countries, and have 4,800 patients. And one of the later analyses, this was published in 2014, but in 2018, they looked at the Ramadan fasting. And just to give you the highlight, Ramadan had significantly lower prevalence of symptoms and signs of volume overload compared to patients hospitalized in other months. Atrial fibrillation and other arrhythmias were significantly less, and cholesterol was significantly lower. And being hospitalized in Ramadan did not actually give you increased 1-year mortality. So this is quite simple. And this is a large study, the 4,000 patients that were studied over the course of 1.5 years. So the conclusion is that it does not seem to increase congestive heart failure. However, the recommendation if a patient is recent acute heart failure decompensation, they should refrain from fasting for at least another month. So the month before Ramadan is very important, because what you want to do, put them back on their medical therapy, let them settle down and get back to a baseline. You don't want them to start fasting when you're increasing diuretics or adding MRA or ARNI. Now, that's the key point. So you need a month window at a minimum after heart failure decompensation. Now, this is a study from Saudi Arabia, and it's very nice because they actually put the abstract in Arabic. I thought that was very interesting. And this group has published extensively on, this is the first author actually of the paper from 2004 about the cardiovascular disease in Ramadan. So what did they see here? Functional class, which is the surrogate for how you feel with heart failure, is actually better even in the advanced heart failure patients during Ramadan. So the really severe heart failure patients who are looking at an LVAD or transplant, they actually improve their functional class and they have less likelihood of decompensation. So there is definitely a benefit, positive benefit to Ramadan as long as they stay on their medication. Now, the problem is you are having studies that were done mostly in the Middle East or Gulf areas. We also have some studies from South Asia. We're not sure in patients living in American and European countries where fasting could be 2 or 3 hours longer. So we don't really have any prospective data, but I think the same general rules apply. So this is an older study. This is the one from Qatar. So Justin Suwaidi and Hajar from Hamad Heart Center. So does hospitalization for heart failure occur more frequently in Ramadan? This is a population-based study. And they looked at all Qatari patients in Qatar over 10 years who were hospitalized with heart failure. And they looked at presentation during Ramadan, 1 month before and 1 month after. And they looked at hospitalization patterns. This is 20,000 patients over 10-year periods. And basically, the overall mortality was 9.7%, which is what you expect with heart failure. 56% of these patients were diabetic, and the number of hospitalizations was not significantly different in Ramadan than otherwise. So there's actually a very nice systematic review that's recently been published, and I think it's very nice to look at it. They look at all of the possible outcomes. This is the same group that published the Gulf Coast study here, where they were looking at patients with atrial fibrillation, and here they looked at patients with heart failure. And in general, there's no statistically difference in any of the metrics during Ramadan or otherwise. So, however, the caveat, these patients were being followed in a cardiology clinic dedicated to heart failure. So they were being monitored very closely. This is the older study from Qatar, and I think this is another important trial showing the difference. So in summary, in patients with chronic heart failure and reduced, this is the Saudi study, I'm sorry. This is the group of patients with reduced ejection fraction, not preserved ejection fraction. There is safe and non-adherence to medication is actually what caused decompensation during Ramadan, not Ramadan itself. When they traced the background, that was the issue. Now, there is, let's repeat it, I'm sorry. So you may have seen this paper from Naveed Sattar's group, actually, in the UK, and they have come up with a fairly comprehensive set of recommendations for cardiovascular disease specifically, which I think would be something to adopt with the, the DAR Alliance. This is something that's a little bit different. Now, what did they look at here? They define patients who are high risk and very high risk, who must not fast. Advanced heart failure, who is that? That's a transplant patient, a patient with a left ventricular assist device, or somebody on a transplant waiting list, because you don't know when they're going to get the transplant. Secondly, patients with severe pulmonary hypertension, which includes women with RV dysfunction, should not fast because they're on very powerful vasodilator therapies that can cause hypotension at any time. Now here, this is a little bit controversial because they did not refer, they referred in the text to the DAR risk calculator, but it wasn't entirely clear how they came up with this group. Now, severe heart failure, hypertrophic cardiomyopathy with obstruction make a lot of sense. Because if you have hypertrophic cardiomyopathy, you have a fixed cardiac output. If you become vasodilated or hypotensive, the gradient increases and you will have a syncopal event. And also patients with severe heart failure, i.e. on triple therapy with multiple hospital admissions, probably should not fast. The other one, which I found a little bit controversial, is the ICD. Once you have an ICD, you expect to be protected against the arrhythmia. So I don't think that's reasonable if a patient has not had recent ICD shocks or recent ventricular arrhythmia. In fact, it's probably the reverse, where you're actually better protected when you have the implantable device than without it. So there are some things that are just basically based on consensus. So medications, this is a critical point. I think Dr. Fawzia covered it beautifully, but remember what's different in the heart failure patient. They need to be given diuretics to avoid congestion. They are also getting high doses of valsartan sacubitril, which is a powerful vasodilator. They're also getting SGLT2 inhibitors. So they need this is not like hypertension. They need the whole gamut of this so that they do not have a decompensated event. So the problem is some of the medications we give are given twice or 3 times a day, like hydralazine, for example. So how do you manage that during the period between iftar and sahur? Next, dehydration, electrolyte imbalance is really important, and patients on diuretics, typically, my recommendation is to tell them to half the diuretic dose or not. Okay. Can I have one slide back? I'm almost done. Yeah. All right. So Electrolyte imbalance is really important in the heart failure patients because electrolyte imbalance, especially hypokalemia and hyponatremia, leads to serious ventricular arrhythmias. And monitoring the electrolyte balance is very important. One other thing our patients do during Ramadan is they overdose on dates, mango and banana and everything that causes the potassium to go up when they are on triple therapy, including an MRA. So this is important in the negative hypokalemia and in the positive as well. We generally don't start diuretics as antihypertensive in the fasting patient, and if the patient is on diuretics for heart failure or antihypertensive, adjust down, especially loop diuretics during the hot seasons, and almost all the heart cardiac medications except for Entresto, secretal valsartan, are typically once a day. So just to conclude, I think we have ample data that Ramadan is actually a good thing for our heart failure patients, and close monitoring and supervision plus prospective medication adjustment allows the heart failure patient to fast and gain the sawab of Ramadan, and also actually improve functional class and many other characteristics. The benefit is seen in patients with preserved as well as reduced ejection fraction. The very advanced patients, probably the ones on transplant lists or advanced devices like LVAD, I think should not fast until we have other ways to manage it. Thank you very much.